Good afternoon, and welcome to our Regional Geriatric Grand Rounds. I'm Rick Smith, a geriatrician and internist at Hayward and the Regional Elder Care Coordinator for Northern California. I'm also the moderator of this geriatric series. Our program today is Alternative Medicines for the Elderly. It is estimated that 30 to 40% of the elderly patients that we see seek alternative care methods. Today, we will discuss some common problems in the elderly and some of the alternative methods of treatment. Excuse me. Joining our discussion today is Dr. Catherine Gunderling, Assistant Professor and Director of Medical Education in the Department of Internal Medicine at the University of California, Davis Medical Center, and Dr. Harley Goldberg, TPMG, Director and Coordinator of Complementary and Alternative Medicine. Thank you both for joining us, and welcome to you.
Thanks.
I would like to remind our viewers before we begin that you may call in at any time during the program. Our telephone number is 8-427-2190, and the outside number, as you see on your screen, is 510-987-2190. Well, thank you both for joining us. The issues of alternative methods of treatment are an important one for this population particularly. And there are many reasons why people utilize alternative methods of treatment. Some of them have to do with quality of life issues. I suspect that most of them have to do with quality of life issues. And there are huge issues as we get older related to the quality of life. Catherine, why don't you begin us off with a discussion about why people utilize alternative care methods?
Sure. I think it's an important topic. The quality of life is particularly important for the older patients. The first slide is just a simple cartoon which illustrates what many of us would like to have for quality of life. On the vertical axis is quality of life. On the horizontal axis is years of age. And as you can see, what I think most of us would like to have is a very high quality of life right from the very beginning, nice and healthy all the way through life, and then at some designated point in ripe old age just to drop dead. That's what a lot of people say they would like. Right. But isn't it interesting to note that many of the medical therapies that we have now are really changing that. We're reducing the incidence of sudden death from myocardial infarction, from stroke, by a lot of the therapies that we're providing our patients. And so what does this lead to? But patients able to live even longer, but giving them the opportunities then to suffer from more of the chronic diseases, such as Alzheimer's disease, osteoarthritis, etc. So that the other line that angles down indicates that people can actually live longer, but the quality of life may go down as they suffer from these chronic diseases. And I think that that points out why a number of older people are interested to try to use alternative or complementary therapies to improve their quality of life in the extra years that they have.
Absolutely. And it may very well, as time goes on, give us an opportunity as physicians to offer more in our armamentarium to support some of the things that are alternatives or that we view as alternatives at this point. Certainly as a geriatrician, we often will shudder at the idea that the rectangularization of morbidity and mortality, in fact, doesn't really occur. That is, you live a lot longer with chronic diseases potentially with the therapies we have, and that's a real issue for all of us. There has been a history of alternative methods of medicine other than what the Western kind of medicine that we're trained in. The history of alternative medicine has been forever, but in this country it seems that it has really taken off. And I think it's important for our audience to understand why that has happened and why it's happening so aggressively now around us. Do you have some comments about that?
Well, I think there are three key events and trends in the 1990s that have led us to where we are today. Here talking to you about complementary medicine, certainly 10 years ago, none of us would have been here. We all knew that patients were trying other things, but they weren't using them to such an extent, and there wasn't quite the interest that there is now on the part of both the patients and the physicians. So I think there are three things, and this has not been studied well, but this is my guess about it, that really led to the present interest in complementary therapies. The first is the establishment of the Office of Alternative Medicine in 1991. And at that time, Congress set aside $2 million to fund this Office of Alternative Medicine to start doing some basic research on some of the, at that time called alternative therapies, that might actually turn out to to be of benefit to patients. This $2 million has since ballooned to over $50 million, and so there is money coming in to offer research on a number of complementary and alternative therapies. As soon as you have the academic institutions involved, and as soon as there is money to perform research, then of course you have more people interested. The results of that research gains attention. The attention of the press then becomes known to the public. So that's one thing. The second thing is the Dietary Supplement Health and Education Act, which was passed in 1994, and that was also an act of Congress. And there were a couple of key congressmen who were very interested to make this new category of medications, foods, whatever you want to call it, ended up being called dietary supplements, much more available to the American people. And the Dietary Supplement Health and Education Act is key because it was right in the mid-1990s, as many people will remember, that we started hearing about ginkgo and ginsana and garlic and many of the dietary supplements that people are now using. All of a sudden we were hammered with advertisements for these products, and so people became aware of them. And of key importance in that is that the manufacturers were no longer required to demonstrate safety and efficacy in the way that pharmaceutical manufacturers have to, spending many millions of dollars, 10 to 15 years in research. Also, they were able to make claims about what these products could do, and they were able to put suggested doses on the labels. So previously, say 15 years ago, you walk in the health food store, you might see saw palmetto on the counter, but you wouldn't have the foggiest idea what to use it for, how to take it, what dosage to use it for. But now all of this is being provided as information to our patients. Mm-hmm. And lastly, I think that the internet has played a key role in the 1990s in our interest in and our patients' interest in complementary and alternative therapies. As you know, at the click of a button, we're receiving information on all different types of dietary supplements, different types of physical modalities, mind-body interface from all over the world. Mm-hmm. And so we have access to this information that many people are interested to try. And I know that a lot of that has affected you folks here at Kaiser.
Absolutely, absolutely. It is interesting to know, a couple of years ago, I think Newsweek had an article to talking about the largest consumer group growing in buying computer and getting on the internet is the elderly. It's sometimes a scary thought, but indeed more information, we believe, does help things along. In Kaiser, it's also been it's become very up front and on people's minds, very popular, as it were, this idea of complementary alternative medicine. Harley, why is it happening like this in Kaiser? I mean, you have a regional position, trying to lead the charge in this area.
Well, the Kaiser situation really does parallel that which is happening across the country as a whole, and at the same time that this information was becoming more familiar to our membership, it also was becoming more familiar to physicians as well. That happened because of a landmark study that was published, a survey that was published in the New England Journal of Medicine, 1990 data published in 1993, and redone in 1997 data published in 1998 in JAMA by David Eisenberg, showing the amount of use by members and by patients across the country in complementary and alternative medicine. In the 1993 article, it was 3 out of 10 patients. In the 1998 article, it was 4 out of 10 patients. And a similar survey done locally in the Bay Area was 5 out of 10 patients. With that amount of information coming to our patients and members, and at the same time new information coming to providers and physicians, the questions, the problems, the confusions that surround an area where there are modalities and methods being used to treat conditions that don't have an evidence base behind them is a very difficult one. How does the patient, from their point of view, decide what's appropriate to use and what's not? What might be safe and what might be harmful? How do the physician and other providers in our organization counsel patients on how to use those things? Because there was cross-disciplinary issues. In other words, it wasn't just in the Department of Medicine or the Department of Pediatrics or the Department of Surgery. It was across all spectrums of our population. The executive offices, Dr. Klein initiated at that time an office to coordinate developing a look at what the evidence says around each of these modalities, in a case-by-case and individual basis, providing summaries of that information to our members, but as equally importantly to our physicians and healthcare providers, to give them the information they need to make the appropriate healthcare decisions. And toward that end, an office was created, and I'm the coordinator at this time of that office for complementary and alternative medicine. We basically have an advisory panel. We have commissioned work groups to review the literature and have developed summaries of the literature on the first series of 4 or 5 areas, which will be coming out at the beginning of next year to primary care and a host of other providers, and will also be available in the clinical library and as many ways as we can make it available through video conferences such as this as well.
And you know, one of the problems is the data that's available. Trying to sift through that and understand it becomes very complex. So as we go through this discussion, you'll be asked multiple times what your opinion of the data might be as we have the discussion. Now, that's a Kaiser look in terms of surveys and how people utilize these alternative methods of care. What about nationally? You know, are we within Kaiser? Are we similar to what you see outside of Kaiser in terms of people using alternative care
Well,
methods?
specifically in the older population, there's not much data as far as who is using what. One of the large national surveys in the last couple of years did happen to look at the subsegment of patients over the age of 65. It was a general survey of English-speaking patients in the population. And this survey showed that of patients who were over the age of 65, that about 30% of them had used something that they were calling alternative therapies. And I say that they were using because that would include things like chiropractic and a few other things that we might not necessarily say would be unconventional. But I think it was higher than many of us expected in that particular population of patients. At 30%, that was fairly significant.
And probably in California it would be even higher. if you
Well,
were to
I
survey.
think that's a very important point for a couple of reasons. Number one, because we know that in California there is availability of many more things, and I know that you folks have done a survey here at Kaiser as to what people are using in this area. But in general, I think people are using quite a bit more of this in California. But I think even more important than that is that we have people from so many different parts of the world here in California, many different cultures, and these people bring with them a lot of the traditional therapies that they are using or have used in their own countries. And so what we're doing in a way is almost like a smorgasbord of things to try for what ails us. We try a little bit from this culture, a little bit from that culture, and see what works. So making our own culture out of it. But yes, I do think that it would be even more important because in this survey of English-speaking patients, it would completely have out of that survey, for example, people who've been born in China and elderly Chinese who may have a very high incidence of use of medicinal herbs and or acupuncture.
Well, in this survey, is there some sense of what alternative therapies were and what were used?
Yes, they actually specifically defined it for this particular survey. And one of our slides here illustrates that. In this survey, the most commonly used therapies was chiropractic was actually number 1 on the list at 11%, what they called herbal therapies at 8%. But keep in mind that the term herb is often used very loosely to mean trees and plants, and even sometimes dietary supplements that aren't plants at all are included in that. Relaxation techniques, which can include a variety of things, and actually 4% with high dose or megavitamin use, which I think is very important because we know that certainly megavitamins can be quite dangerous to patients, particularly elderly patients.
And you know, the elderly particularly use a number of different alternative medicines for a variety of reasons. And I think it's important to note the chronic illnesses, the most popular chronic illnesses are what they utilize it for. And I think you actually have a slide.
Correct.
about that.
Number 1 on the list is osteoarthritis,
Right.
and in general joint problems. Back pain was number 2 on the list, reasons that older people would seek complementary alternative therapies. Heart disease, and of course diabetes, because these are things that we see in a lot of older patients, and something that they called allergy without specifying too much better. I suspect most of that was probably related to allergic rhinitis, sneezing, sinus symptoms, that sort of thing.
You know, what do you think? So people go to the chiropractor or acupuncture for back pain or use herbal medicines. Why is this such an important issue for us to consider as we prescribe or think about treatments that we are knowledgeable about?
Well, I do think that it's important for physicians to be aware of the use. Many so-called complementary therapies might actually be fairly safe to use, but an example of something that would be important to know about, for example, many of the so-called herbal products that energize you may contain ma huang, which can increase blood pressure. With many older patients already on medication for high blood pressure, it's important to know if they take something that may increase their blood pressure and therefore either counteract the medications, or we would find ourselves increasing the number and quantity of medications that we're giving patients, not realizing that they might be using something that would be interfering with the treatment that we're giving. So I think that there are a number of complementary therapies that are safe to use, but there are many that physicians really need to know about.
You know, that brings up an important issue within our system. Harley, what are we doing to educate providers about the huge number of drugs? If you get the names of them, which often it takes a specific question, are you using any home remedies or other non-prescription therapies?
Let me come back to actually what we're doing in our system after I address the question of why, which is what you were really broaching. Why does a patient seek out complementary alternative medicine? And that can be summarized based on demographic literature that's already been produced. Actually, in May of '98 in JAMA, there was a nice article by John Aston describing why patients use complementary and alternative medicine. And you can summarize from that data that patients actually use complementary medicine either for relief of a chronic condition, and they're pushed to seek more help, or because they're pulled from a belief of a more holistic approach to their health care, because they believe in a mind-body connection or have some other belief systems that orient them toward other modalities and philosophies of healthcare. And when you ask the patient in the interaction, in the clinical setting, and you're going through your history, if you have a don't ask, don't tell philosophy, you will never know. And then all the potential toxicities that Catherine was talking about, and all the potential harms that can come from not knowing about what's being used, and we'll go over some of that in more detail later, can occur. What's critically important is that we actively ask. And I always now put it right after medications. I just include in my mind other medications and expand that to complementary and alternative things in general. And each time you'll be shocked, if you really ask, how frequently you'll get a tremendous amount of information. All that is about trying to determine why the patient is seeking out this therapy. Because if you can align with their aim, you can establish rapport, understand their intentions, and begin to work with them as a team to improve their health care. And at the same time, they'll feel they can trust and confide in you because you've been willing to talk about something that heretofore was a taboo.
Well, you know, I've been struck by when we ask, though, they come with a whole bunch of things and say, are these okay? And by the way, I don't want to take a whole bunch of prescription drugs, which is an interesting
that's
phenomenon.
critically important. If we're going to talk about compliance, for example, we have to go there. We have to talk about what's motivating the individual, what their beliefs are, and there may be other cultural beliefs, as Catherine was describing, if they come from a setting that uses herbal remedies or any other methodology. The WHO has stated that in 80% of the world, the primary care is what we would call alternative or conventional care. And it's our actual cultural belief system that describes what we would call conventional Western medicine. Patients don't necessarily fall into that as neatly and succinctly as we would sometimes like to believe when we're operating out of our own belief system. Having said that, what we are doing, to answer your original question, is producing information that will be coming out, as I was alluding to, in about a month, that will include a series of monographs on the most commonly used herbs, and also providing a website, and also on the clinical library there will be information in a complementary and alternative medicine area. We've obtained an agreement with a publisher of a text called Professional's Handbook on Complementary and Alternative Medicine to take the most commonly used 25 monographs from their text and have that online. The real issue is, how do we get information in a practical and usable way to the clinician? And that's very difficult in our busy, hectic lives. So we will have it online. We will have hard copy handouts mailed out. We will be available by phone. Should we be able to help you, call and we'll do our best to find out the information you need. And all of that takes time, however, and I understand that therein is the rub.
Right.
But also by having video conferences like this.
Well, you know, and the other issues, because we have such an integrated system too, we do depend on pharmacists, for instance, which I know that there's a program
Right.
developed or being developed for the pharmacists to be able to be educated in the
Right.
interactions that occur.
Thanks for mentioning that, Rick. Also, we'll have a CME program for pharmacy put out at the same time that we roll out these other things, so that if it's an area where you don't particularly have an interest, but your patient wants to have information, or for whatever the reason, it works out better to simply suggest that they go down to the pharmacy and talk to the pharmacist about the herbs and or supplements that they're using and the potential for interactions.
Right.
One last thing we'll do, and we'll roll out simultaneously, is an attempt to capture an adverse reporting system. Largely, the toxicities and interactions, particularly the interactions of these over-the-counter herbal or supplemental remedies, is unknown. And we need to accumulate that data. And where better can that be done than our organization? So we'll attempt...
If people will report it.
If people will report it. And we will attempt to put out a system that makes it as user-friendly as possible by capturing information from members when they purchase things at the pharmacy, and as well capturing information from providers, physicians, and we'll roll that out in about a month or so.
Yeah, and you know, this is very relative to our practice, because you know, everyone's practice is very, very busy. You have some insight into what kind of patient is using alternative care methods or drugs and things like that. It does correlate, in fact, with office visits. Is that
It
correct?
does. In fact, about 5 years ago, when we were all becoming interested in this phenomenon as it was unfolding, we thought, well, probably the users of complementary or alternative therapies are dissatisfied with the medical system, and they're not using conventional medicines or coming to see doctors anymore, but rather they're just using these other things. In fact, that turns out not to be the case at all. The highest users of the complementary therapies are the highest users of conventional therapies. So if you're looking for sort of a simple thought or idea about how to identify patients who might be using them, it would be the patients who are seeing you the most are probably those patients who are also using complementary therapies and seeking out complementary providers the most.
Well, that's an interesting thing. So the patients on all these medicines that have multiple chronic diseases, their Coumadin or their INR may be elevated because of a drug they're taking from that's an herbal medicine or something.
Absolutely.
Mm-hmm.
This is a scary yet important fact, I suppose. Well, you know, as we talk about alternative medicines, it's such a broad topic. I think it's important to organize it in a way that our audience can get something from that, and that is to talk about some specific diseases. And I know that you have some expertise and interest in some particular diseases. Let's start out with Alzheimer's.
Okay. Yeah, I thought a couple of the things that we could talk about today were some of the most common ones that we see in the older patient population. Just a reminder about the 3 stages of Alzheimer's disease, which I think are important to review, because many of the medications and complementary therapies that are used for Alzheimer's are relevant to the different stages of the disease. And of course there's tremendous overlap of these stages, but just as a very quick reminder, the first stage of Alzheimer's is often hallmarked by changes in behavior or mood. You may also see recent memory impairment, and it often affects work-related duties. You may also see confusion about directions to commonly traveled locations. Now, I experienced that coming into the building today, but you all know what I mean.
We might have a medicine for you after this.
Second stage of Alzheimer's, we often think of some of the clinical things that we see with it: visual or auditory hallucinations, difficulty with reading or writing, and it's at the second stage that we often see more problems with behavior. Third stage characteristics: the first one, self-care skills decline. Patients may become mute, and they may lose control of bodily functions. And of course, this is a very difficult time, and particularly the care providers are very interested in finding something else that may be of benefit to their patients. The risk factors, very briefly, most of us are familiar with. Genetic predisposition. We do know that there is a genetic predisposition to Alzheimer's disease, and of course previous head trauma. And certainly there are some athletes here in the Bay Area we're all concerned about who have had a lot of head trauma. That's the type of person we would be concerned about developing types of dementia syndromes later on in life. Aging, we know from our previous experience and also from that graph I showed at the very beginning, it's one of the things that's associated with increased incidence with age. And another interesting association is little or no formal education at an early age. So it seems that when we do stimulate our kids with reading and writing and activities that exercise the brain, that somehow this may provide a protective factor later in life.
But maybe not soccer, although I'm just joking. Soccer is a great sport. Well, I think that those are all important issues, and it's interesting that you bring up the different stages of Alzheimer's in a very clinical set. That is, you bring up the 3 stages and describe them in a way that is what the caregiver sees, and the provider, of course. But really fundamentally, these are behavioral or issues of daily living activities. The caregiver often will come and ask for something to be done. The patient will sometimes do that. There's a lot of confusing information out there about what can work and what can't work. What kinds of advice do you have, or what kind of comments do you have about things that are available right now?
Well, let's very briefly review the present pharmacologic treatments for Alzheimer's. Most of you are familiar with this, so we won't belabor it. But you're familiar with the last couple of years, some of the studies that are coming out looking at the possible use of estrogen replacement therapy in women as a possible preventative of Alzheimer's disease. Some of the anti-inflammatory agents have been tried as well, with not too much success. Drugs such as Tacrin, nimodipine, and certainly some of the neuroleptic agents have been looked at, although the neuroleptic agents have been associated to a certain extent with worse outcome. We also have non-pharmacologic treatments that have been used, and I'll just list some of those. Behavioral therapies, psychotherapies, and perhaps some of these might be actually considered complementary. I don't know, you can comment on that. Physical and mental stimulation of all different kinds. There are programs in memory training for exercise and memory training, as well as in occupational therapy. So there already exist a variety of non-pharmacologic therapies, but as you know, not too many of these help all that much. None of them really reverse Alzheimer's disease, but some of them may provide some benefit. So these are short of the complementary therapies, some of the other things that we see patients trying.
Right. These activities often bring up the caregiver involvement and support the idea that someone can stay home for longer periods of time if they're doing something like memory programs. We know that the more comfort that caregivers feel, the longer a demented patient can stay at home or stay out of institutions, and that's an important aspect. But they also are always looking for other kinds of treatments that are inexpensive or expensive that show some promise because of the way they're advertised. Is there any evidence that any of those things work?
Well, they are trying all sorts of things out there. There was one survey that was done looking at use of complementary therapies, and this is a survey of caregivers, which is very important because normally we ask patients, well, what are you using for this particular problem? But if you ask the caregivers who are taking care of the folks who have Alzheimer's disease, they're trying things like mad. There was one survey that I have that was one of the few surveys that's been done of only 100 of the caregivers, but it was very interesting. 55% of them had administered at least one complementary therapy to the loved one, and actually 20% of them had administered 3 or more treatments. And so many of these patients are receiving a lot of different types of treatments. And the ones most commonly tried were vitamins, by far and away the greatest. I'd suspect a lot of that would be vitamin E, but I'm certain that they're trying different types of antioxidants, vitamin C in particular, beta-carotene, etc. Health foods, they had a category called health foods and didn't necessarily specify that to a greater degree. That was 27%. Herbal medicines, 11%. And again, this is kind of a more generic category that may actually include other dietary supplements. Smart pills, 9%, and other home remedies, 7%. So probably at the top of the list are vitamins, health foods, and things that the caregiver can actually give to the patient to take by mouth. That's probably at the top of the list.
And the other things that come to mind are things like ginkgo, which has in fact some data to support its use.
Yes, I've included just a little bit of information about ginkgo biloba on one of the slides here. Ginkgo is a fascinating plant. It's actually not an herb, it's from a tree. And all around Northern California you can see ginkgo trees. This year they're beautiful. They put out bright yellow leaves. They're just beautiful. And the leaves are called biloba because they're bilobed in shape. And the ginkgo tree is one of the oldest trees in the world. It survived the age of the dinosaurs. So however it's managed to survive, it's an amazing type of plant. In any case, there is a little bit of evidence, most of which has come out of Germany. We do have one study in the United States that's been very interesting and provocative. I've included on one of the slides some of the studies that you might be interested to look at. There are studies by Hofferberth as well as Kanoski that have looked at use of ginkgo biloba both in either early or early to mid-stage Alzheimer's disease. And they found, fortunately, that it seemed to have very few adverse effects and may have had a little bit of benefit with respect to a variety of parameters. There are many things that you can measure, such as change in behavior, whether it seems to calm Alzheimer's patients down a bit, whether it seems to help their memory, helps in their daily activities. So there are a lot of different things that you can measure. One of the more significant articles is the article by Letzel, in which he reviewed 44 studies that looked at efficacy of ginkgo biloba, tacrin, and nimodipine, all to see if they could be of benefit. And in that particular review, they all looked like they could be of some benefit to patients with Alzheimer's disease. Certainly not by any stretch of the imagination a cure. But another important aspect of these was, again, they concluded that ginkgo biloba seemed to have the fewest adverse effects of any of the things that they tried. And many people are familiar with the Labar's study, which was performed here in the United States and was in JAMA, I believe, last year, that looked at the use of ginkgo biloba in mild to moderate dementia. And most specifically in that, the caretakers perceived a significant benefit compared to placebo in how easy or difficult it was to help take care of those patients and in the social functioning of those patients. So I don't think we're looking at a cure here. I don't think we're looking at a magic bullet, but I think we're looking at enough provocative data that ginkgo biloba is worth researching more to find out what role it may have in not only Alzheimer's disease but also vascular dementia and other types of dementia.
And one of the issues about ginkgo is that it does have an antiplatelet effect.
Yes,
as well.
Right. And I think we can probably just develop a few conclusions about ginkgo biloba. Number one, that it does seem to be well tolerated. Number two, that it is probably beneficial for mild to moderate Alzheimer's disease. How much, we don't quite know yet. It is in the process of being studied in a major NIH study. We're participating in that at UC Davis. I do want to call to the attention of the doctors the fact that ginkgo has fairly powerful antiplatelet effects, and so we need to keep this in mind, particularly in patients who are taking warfarin. We might want to think of it as an aspirin, and would we want patients who are on warfarin to be taking aspirin? So do we know exactly how it might affect these patients? No, we don't, but it makes good common sense in something that has a powerful antiplatelet effect to be careful in patients who are otherwise taking aspirin, or particularly those who are on warfarin. And so I would recommend that it not be used in anticoagulated patients until we have a little better data on the risks associated with that.
The other thing to note is that these studies, again, largely were European studies and of fair to moderate quality by and large, but it's noteworthy that the patients were patients with dementia. What you'll find in the health food store is juice with ginkgo and ginkgo for everything, and there's no data whatsoever on any of that.
So
particularly in the young, healthy people. And in
there's
most
no data
of
on
this,
prevention that ginkgo prevents.
on prevention, and also when it's advertised as a memory enhancer, particularly when it's in those drinks. You know, you look on the list of what's in the drinks, it'll be corn syrup, corn syrup, corn syrup, flavoring, a little bit of coloring. The last ingredient is ginkgo biloba, and it's not enough even in there to make a difference. And certainly with young people, we have no evidence whatsoever that it makes a difference in enhancing memory or preventing dementia.
So it'd be a lot cheaper just to get a bottle of corn syrup and put a ginkgo leaf.
That's right. Soak your ginkgo leaf
You
in
may
it.
have a product there to sell. The other thing that would be noteworthy is also the caveat to also place, anytime we're talking about herbal products, on quality of individual products. And just as a quick note, one always has to remember that, in fact, there was a study done of ginkgo products that showed a significant variation amongst different products in the percentage of active ingredient as based on the active ingredients identified for the purposes of that study. Two things to take out of that. One is actually most of the time we don't actually know in herbs what the active ingredient is. We're making some assumptions. Second is that there's tremendous variation amongst products, and having a quality standard to fall back on is important, which brings us back to the déchets issue and the fact that we don't have those in this country right now. Having said that, internally what we have done is we were beginning to develop some quality standards when we became aligned with the U.S. Pharmacopoeia, who is working right now on developing quality standards for herbal products, which is actually much more rigorous and difficult to do than in regular pharmaceutical agents, because you have to do three different standards. You have to do them for the raw products, the extracts, and then the pill form itself. Having said all of that, we have a standard that will be moderated through the Pharmacy Operations Division, and products that we are going to purchase a few herbs, and ginkgo is one of them, and will be on the shelves early next year. And just before that, you will get all the information about them that we were talking about earlier. The products that we will have will meet a quality standard.
It's also worth mentioning that in many of these studies that we look at when we perform systematic reviews of does ginkgo biloba or ginseng do something in when we test it in the clinical setting, that many of the studies have used very different products. And depending on where it was grown, what the climate was like that year, how old it was when it was harvested, the ginseng that I use in my study may be very different than the ginseng that a Korean researcher has used. So the conclusions that I might draw from my study might not be correct for the conclusions that someone else has drawn, simply because, as an example, ginseng has over 28 active ingredients in it, all of which will vary in quality and quantity depending on what product you're using. So it's not quite as simple as saying, well, let's look at all these 44 studies and pull together the results, because the products used in these studies for ginkgo biloba were from different manufacturers and from different sources, so it may not be safe to draw conclusions and compare them.
On that note, you know, one last thing about Alzheimer's that's been very popular and very difficult sometimes for the elderly patients to take is vitamin E. Can you just review very quickly some of the data that has supported vitamin E use?
Yes. With respect to vitamin E, there have been several studies. A couple that I've quoted here, the Sano study, which noted that use of vitamin E resulted in delay of disease progression. And of course, that's what many of the family members are interested in when they're caring for these patients. That was a fairly well-designed study. The Zaman study was a case control study, and that one was interesting in that it showed decreased levels of vitamin C, vitamin E in patients with Alzheimer's disease, as has another study. So the question then becomes, do they have decreased levels of these vitamins in their blood because of the Alzheimer's, or do they have the Alzheimer's because they don't have the adequate levels of these vitamins in their blood? And we don't really know the answer to that. So there are some other studies that have been done. Again, with vitamin E, it's very interesting and provocative data. I don't think we can say vitamin E cures Alzheimer's patients. Many geriatricians are now using vitamin E. I know our own geriatricians, for many of the patients, they're supplementing with 400 international units of vitamin E. But there's also this one little issue of, does it cause increased incidence of hemorrhagic stroke, as was hinted at in a large study that came out in the last year and a half, and we don't yet know the answer to that. It was observational, and it seems to be in general fairly safe, but we need to find out whether the hemorrhagic stroke that was noticed is truly an effect related to the vitamin E or whether it's something else.
And some of the studies have shown that it takes 2,000 international units a
Right,
day
much larger doses.
to,
So exactly how much it might require, we don't know. Some geriatricians, and you're probably better able to speak about this, 400 international units, some 800, some 1,200, usually seems to be in increments of 400.
Absolutely. And that's been the problem, is that the GI upset, that in my anecdotal experiences, has been so great at high levels that and these are obviously, these are very sick patients anyway, or have other illnesses. So. Yet, in terms of other treatment modalities, I guess they would be considered also alternative care to some. However, I think that as a geriatrician is the primary care providers viewing this program, probably these other treatments are not really so alternative, except maybe DHEA.
Right. The few others that I added on the list, which are being looked at in some studies now, music therapy, and certainly many care centers for Alzheimer's patients already include music therapy. To me, that's self-evident that if people are listening to music that they like, they might feel better and behave better, and it might make them feel more secure. So that doesn't seem to be any huge clinical mystery to me. Phytoestrogens are being looked at as well now. This may be related to the same issue as hormone replacement therapy. If we have people greatly increase the content of soy in the diet, could this help to prevent Alzheimer's disease or even treat Alzheimer's disease? And this brings up another question, which is, we're familiar with the diets of other people in the world. For example, in a lot of the people from Asian countries who have diets that are high in soy products that have a lower incidence of stroke and myocardial infarction and many of these vascular diseases and dementia-related diseases. Is it because they use these products in their diet? Well, we don't know if someone who is of entirely, say, European heritage takes a diet or uses medicinal herbs that have been characteristic of another country and another genetic heritage for thousands of years. Will it have the same effect in someone from a different part of the world? Nobody ever addresses that, and we do know, for example, that medicines may have different effects depending on whether you're of African American heritage or no matter what your genetic background is, there are different effects. So this probably applies to complementary therapies as well, but we don't know.
Still a lot to
learn.
Well, there are some things related to osteoarthritis that are very interesting, and that I certainly have used in my practice that would be considered, again, alternative medicine issues or things. Why don't we only have a few minutes left. Why don't we review those very quickly?
Sure.
And give the audience the information that's available.
Sure. Well, certainly with osteoarthritis, it affects so many people. I think there are over 16 million Americans now with problems with osteoarthritis, and it is one of those things from which people suffer greatly, just chronic pain. And so osteoarthritis is at the top of the list of diseases for which particularly older patients will seek complementary therapies. And certainly at the top of that list has to be glucosamine. So I did want to just mention about glucosamine because so many people are using it with or without our advice now.
Right.
But interestingly, this is one of the few dietary supplements for which we actually have some pretty good emerging data. And I have a slide which just mentions the fact that we have two very good quality studies which have shown glucosamine to be more effective than placebo in treating the pain related to osteoarthritis and joint disease. It has been found to be at least as effective as non-steroidal anti-inflammatory agents, and it's associated with fewer adverse effects. Now, we don't have millions of people using it for a long period of time yet for us to be able to feel terribly comfortable that we know all of the potential adverse effects or interactions with other medications, but so far it seems to be fairly safe. And many of us know our patients found out by giving it to their dogs, but veterinarians prescribe glucosamine for their dogs with joint problems, and the dogs got better, and so humans are interested in using it too. And so it's interesting that some of these dietary supplements we're using now, we're using because they have been used in animals with some success. So glucosamine actually has some fairly good data behind it. And you might want to mention about use of glucosamine in Kaiser. Is that something that's being used here now, or?
Basically, in TPMG, the data is the data that is external as well, and the same studies have been looked at, and will be actually a work group will be commissioned early next year on arthritis. But as you said, there are two fairly good high-quality studies that have shown equal efficacy to nonsteroidals and less adverse effects. Might be noteworthy that the most common adverse effects usually are GI type mild symptoms, although those same effects were noted in the placebo group almost at the same rates. There will be supplement. In fact, most of the facilities actually have this supplement on the shelves, although it's not been institutionalized from a regional standpoint.
In terms of arthritis, are there any other alternative medicines?
One of the things that a lot of our patients are using now is this new supplement we've seen advertised a lot lately called SAM-E, which I think they gave it the friendly name of SAM-E because it's too hard to say, S-adenosylmethionine. But this is a compound that's been used in Europe for quite some time, both for depression and joint pain. In my opinion, we don't have as good of data for the SAM-E as we do for glucosamine. If you look, for example, just in Medline, there's virtually nothing about this product in Medline as far as good double-blind, randomized, placebo-controlled trials, and even looking in other databases such as Biasis and Cochrane, which I've done in recent months, there's virtually nothing on SAM-E. There's one study of 734 patients, so it was a fairly large study. The design was not bad, not great, and in that particular study it showed that it was about as effective as naproxen for treatment of joint pains, but better tolerated than the naproxen. Now, I don't in any way advocate its use at this point because I think we just don't have very much data on it. It is something that's brand new here for us in our use of it, but it is very popular with patients, so they do need to know that a lot of them are coming in asking about it or they're already on it. So we're trying to glean a little bit of information from the Europeans about it, but it really has not been well studied yet.
Well, I appreciate you sharing this with us. We're winding down in terms of the time we have allotted. Obviously, this is a huge topic area, and we'll have to revisit it again. I'd like to hear final comments, and Harley, if you could address the issues I'm sure that the audiences are interested in terms of alternative methods, alternative care methods of acupuncture and chiropractic. Where do we sit with that in the organization in terms of
the organization's approach to complementary and alternative medicine is basically to separate out some of these very confusing areas into those things that are used for health promotion and wellness, those things that are used for treatment of disease, and there are a few things that fall in the middle between. Those things that are used for health promotion and wellness, and some of which have interesting information. For example, there are a couple of studies that show that elderly use of Tai Chi, it decreases the incidence of falls. Those classes, Tai Chi, yoga, mind-body programs, etc., will be available by and large through health education department activities. That is to say, they're self-referral. Those things that are actually explicit treatment of disease conditions and will be dependent upon a referral from a physician will be integrated into the treatment program, much like everything we do in our organization, an integrated medical care system. And those things will come, for example, acupuncture is being used for chronic pain in most of our facilities, and that's what it's being used for in the context of a chronic pain program, is one piece of a total program. And manual therapy is only available through physical therapy departments. We've had another video conference on chiropractic, which people can refer to.
Okay, thank you very much.
Just to say that I think really ultimately our goal is good patient care. And the interest in complementary medicine should be that if we can find therapies that are truly beneficial for our patients based on good quality data, then it's something that we as physicians need to know about and need to be able to discuss with our patients. But it's also our responsibility to look toward those things that may be problematic to our patients, and we have a lot that fall in both categories in complementary medicine.
Right, and it sounds like there's a lot of information coming out now because of this renewed interest and money for research.
Right.
Well, we have the history of medicine that gives us some insight of where we've been and where we go.